and in fact, it has happened. Okay. We're going to start with Bruce Strober. As I said, Bruce is originally from New York, but he's now the clinical professor of dermatology at Yale University in Connecticut. And Bruce is going to talk to us about advanced.
They had to go to a 0. Now you can see here these efficacy data are modest. Only 1 in 5 patients achieved the benchmark. But apremilast is a modest efficacy drug, so no surprises here. And not surprisingly, the same tolerability issues arose in this study regarding headache, nausea, and diarrhea in about 1 in every 5 patients for each of those adverse events. Now, a different drug that's oral, yet possibly going to go into the same space as deucravacitinib. It's a drug that's not yet approved by the FDA for any indication. It's a specific TYK2 inhibitor by binding the allosteric domain of TYK2, not shared by the other 3 members of the JAK kinase family, JAK1, 2, and 3. More specifically, deucravacitinib binds the regulatory domain of TYK2 that isn't shared in the JAK1 through 3 members of the family. So it's oral, it's once daily, highly selective, 100-fold or more greater selectivity for TYK2 than JAK1 and 3, 2,000-fold greater selectivity for TYK2 versus JAK2. And specifically inhibits cytokine signaling that mediates IL-12, IL-23, and type 1 interferon. Particularly interesting is the 12-23 link. Those 2 cytokines we know from past biologics experience, highly relevant for psoriasis pathogenesis. If you inhibit those cytokines, you get efficacy in psoriasis. And here you see the regulatory domain binding is allosteric, subsequently inhibiting the activities of the catalytic domain so that TYK2 is unable to function. The efficacy data are generated by 2 parallel studies, Poetic SO1, Poetic SO2. Each is a identical version of the other, head-to-head with apremilast. And apremilast in the light blue, placebo in the gray, and you can see the purple line is your TYK2 inhibitor, deucravacitinib. Modest efficacy for apremilast as usual, pretty respectable efficacy for deucravacitinib. 59% or 54% at the primary endpoint, week 16, PASI 75. And if you carry these patients out to week 24, you even see a bit more efficacy. Probably safe to say 2/3 of patients over the course of 6 months get to PASI 75. I would say that's efficacy comparable to what you see for adalimumab and ustekinumab, Humira, Stelara. Adverse events, well, deucravacitinib did not have the tolerability adverse events seen with apremilast. As you can see in this slide, headache, diarrhea, nausea highlighted were low in the deucravacitinib arm and comparable to placebo, whereas you see about a quarter of the patients on the apremilast arm seeing headache, diarrhea, and nausea. A little bit more nasopharyngitis in the deucravacitinib arm, but no differences in AEs leading to discontinuation or serious AEs. These are some adverse events of interest, particularly those that you might see in patients receiving JAK kinase inhibitors, serious infections, zoster, arterial thromboembolism, deep venous thrombosis, pulmonary embolism, and then MACE. And in every instance, you can see deucravacitinib performs quite comparably to either placebo or apremilast. And we know apremilast isn't associated with any of these real adverse events. And so if deucravacitinib in this study of a large number of patients is similar, we have a good sense that issues related to JAK kinase inhibition are not gravitating towards deucravacitinib. Laboratory monitoring, similarly, because of the TYK2 specificity, it appears that laboratory monitoring that you might think necessary for a JAK kinase inhibitor isn't necessary for deucravacitinib. For example, no need to measure the CBC to my eye because there's no movement in lymphocyte, neutrophil, and platelet counts, no anemia. Comparable to apremilast as shown here in this table. Similarly with cholesterol, no issues with cholesterol. minimal issues with triglycerides, almost the same as placebo. CPK is a little elevated in some patients, but again, not different from placebo, and no issues on renal function or AST, ALT. So it might be deucravacitinib is a type of drug that is unique in its MOA, different from JAK kinase inhibition, not having some of the adverse events we associate with JAK kinase inhibition, and not necessitating blood test monitoring typically needed for your classical JAK kinase inhibitors. Now, what about the JAK inhibitors for psoriasis? We don't have an approved one. We only can use them because they're approved for psoriatic arthritis, and that would be tofacitinib and upadacitinib, or they're approved for atopic dermatitis, and that would be upadacitinib and abrocitinib, which is a drug unique to dermatology now, manufactured by Pfizer. Tofacitinib, I have found, is very effective for patients with palmoplantar psoriasis, and we published this in the journal Psoriasis and Psoriatic Arthritis. Many cases, I have over 25 patients who basically all show this behavior. If you take someone with palmoplantar psoriasis and you give them a couple months of standard dose tofacitinib, you nearly clear them or clear them in every instance. Baseline, this is 2 months later. Baseline, month 1, month 2, fully clear. This patient is now a year out, still clear. Very severe patient, brought to almost clear after 2 months. Again, I have countless patients who demonstrate this behavior. And I think this means JAK inhibition, at least in the manner by which tofacitinib does it, is a really uniquely effective approach to palmoplantar psoriasis that we don't see with our high potency biologic therapies. They don't do this as frequently. There's something unique to JAK kinase inhibition that leads to this outcome. And the question remains, will upadacitinib, which is now approved for psoriatic arthritis, work as well or better? Well, we'll find out soon. I'm going to start using upadacitinib exclusively for these patients, moving away from tofacitinib, and just see how my first 10 patients do. IL-17A pathway inhibitors, it's well known in rheumatology. They're great for psoriatic arthritis, and we also know they're great for psoriasis. Now they're approved in pediatric populations down to the age of 6. That's the upshot of this part of the presentation. Ixekizumab, very effective at the PASI 90, 100 level, actually more so than it is in adults, down to the age of 6. These are the kids. This is Secukinumab, and I highlight its efficacy at PASI 90, really impressive, 73% of patients at the 300 milligram dose, hitting PASI 90 at week 12, and out week 52, a similar number of patients. And the blue line is etanercept, and the blue histograms are etanercept. There's really no comparison. Etanercept has been a gold standard drug for pediatric psoriasis for many years. Now we can move to IL-17A inhibitors as long as patients don't have a history of inflammatory bowel disease, and that would be the major issue. I will say, as an aside, my preferential drug for pediatric psoriasis remains Secukinumab, because no risk for IBD, very easy dosing at every 12 weeks, and really quiet safety. Bendikizumab is a drug that blocks IL-17A and F, so it's a unique MOA. Blocking IL-17F brings into play another isoform of IL-17 that is found in high levels in patients with psoriasis, particularly in their plaques. So it is believed that IL-17 inhibition should encompass not only A but F to get the full range and potential of IL-17 pathway inhibition. Bendikizumab is not yet approved for psoriasis in the United States. That approval is nearly going to occur. It might even occur or have occurred by the time you hear this talk. In a nutshell, the efficacy of bendikizumab in psoriasis, in my opinion, is unmatched. 91% of patients get to PASI 90, all right? For reference, risankizumab, it's about 75% of patients at that level. So 91%, and at week 52, a similar amount of patients are still at that metric. So you're going to get 90% at PASI 90, you're going to get 70% at PASI 100. You're going to tell a patient there's a 70% chance you'll be fully clear by week 16. So a very rapidly acting drug as well. Again, probably the most potent and rapidly acting medication. The one downside is candidal infections occur in approximately 10 to 20% of patients, depending on the dose used. There'll be a Q8-week maintenance dose and a Q4-week maintenance dose after initial 16 weeks of Q4 weeks. The Q8-week dose will give you fewer candidal infections than the Q4-week dose. And just for perspective, the other IL-17 pathway inhibitors, such as Secukinumab, Efficacy, and Brodalumab, have much lower candidal rates. Somewhere between 2 and 5% of patients experience candidal infection while on these drugs. But the Bendikizumab, again, 10 to 18%, depending on study. So we're all going to have to be, quote unquote, candidologists to take care of patients on Bendikizumab. I predict that most of these patients have mild oral candidiasis, which is easily treatable, and by far the majority of patients didn't come out of the studies when they had candidal infection. So it might be a minor issue that's easily managed. With regard to long-term safety of biologics, and particularly IL-17A inhibitors in psoriasis, I want to point out serious infection rates. You can see all three of the IL-17s currently approved gravitate to about 1.3, 1.4 events per 100 patient years. And that's in line with the SOLAR registry range. That's a real world registry of 12,000 patients with moderate to severe psoriasis. That yellow bar is the range of serious infections. And you can see IL-17s fall within the real world range when they're in their clinical trials. And actually they're very comparable to IL-23 inhibitors. So low serious infection rates in IL-17 inhibitors. So to summarize the IL-17s, we see drugs with rapid response, robust efficacy, more frequent dosing than IL-23 inhibitors. Occasionally they're underdosed at every 4 weeks, I would say. Comparable efficacy to adalimumab for psoriatic arthritis. We know they inhibit radiographic progression with good efficacy for axial disease. Low signal for malignancy and serious infections. Best efficacy for nail psoriasis, no laboratory monitoring. Candidiasis, less than 5% for the IL-17 inhibitors, higher for the IL-17AF blocker. You don't want to use them in IBD, of course, and they work really well for pediatric psoriasis. They join etanercept and Secukinumab with approval in that group of patients. Now, IL-23 inhibitors, we have 3. There's Tildrakizumab, which is our weakest IL-23 inhibitor. I say that because only 2 out of 3 patients get the PASI 75 at week 12, maybe a few more at week 28, and week 28 PASI 90, about 50%, I would say, and 25% at PASI 100. These are low numbers for the IL-23s. For Guselkumab, now you're seeing PASI 75 at the 90% range, and you can see the plum-colored line is Humira, adalimumab, is a comparator. Out a year, you're holding that efficacy pretty well. That's a non-responder imputation. PASI 90, 3 out of 4 at PASI 90 for Guselkumab, and PASI 100, about half the patients on Guselkumab. So half the patients on Guselkumab cleared at a year out. And that's twice the number of patients you saw with Tildrakizumab at that metric. Risankizumab, a little more effective, I think, than Guselkumab, just a slight margin. 3 out of 4, PASI 90, week 16, 4 out of 5, PASI 90, week 52. And by the way, it's about 60% PASI 100 at week 52. And dosing is less frequent for Risankizumab. Everyone should know Risankizumab and Guselkumab because they're now approved for active psoriatic arthritis in adults. So these are drugs you'll get to know. And similarly, they're quiet on the serious infection level, in range with SOLAR, 1.2 per 100 patient years, serious infections. Malignancy, low rates, 0.5 per 100 patient years, and in range with the real world SOLAR registry. So fairly good comfort with regard to serious infections and malignancies in people either on IL-17 inhibitors or IL-23 blockers. So to conclude, the IL-23 inhibitors, robust, long-lasting skin efficacy, high PASI 90 and 100 levels, week 16 and onward. More than 50% of the patients on Risankizumab, Guselkumab are PASI 100 at week 52. with risankizumab slightly more efficacious and a less frequent dosing interval. But both are very nice in terms of their 2 to 3 month dosing interval, very infrequent and probably tolerant of lazy dosing, where some missed doses don't really have great consequence on efficacy. They're sneaky in their rapidity of response. They're not slow drugs. They're not as fast as, say, ixekizumab, but they're comparably as fast as secukinumab. You will see at 4 weeks out, more than half the skin is cleared. And I told you about the dosing laziness. They have efficacy for psoriatic arthritis. I see this very practically in the clinic. Patients do see signs and symptom improvement with guselkumab, risankizumab, and the approvals are therefore justified. And they seem to have TNF level efficacy for dactylitis and enthesitis. Maybe, though, they don't stack up on the radiographic progression issue. So there, I would say more severely affected psoriasis patients should be biased towards TNF blockers and IL-17 inhibitors, but a good choice for the more mild PsA patient that we commonly see in dermatology. No laboratory monitoring, low signal for malignancy, no candidiasis signal for these drugs, and finally, no IBD concern. So a little less concern up front. We don't have to screen for IBD. We don't have to worry about candidiasis. Pretty quiet mechanism of action, IL-23 inhibition. So I end here with the current treatment paradigm.
Worked with at Northwestern for a long, long time. And I had to get this, and we wrote this on the back of a napkin. So it was like the Laffer curve for those people who remember the Reagan administration. And it turned out to be the silliest, most common sense figure I've ever seen. But as we have many, many new treatments going on, I actually think it's somewhat relevant now where it wasn't probably in 2006. So we think of it as the 4-quadrant model, but all it's doing is saying, what are the priorities of the patient that's in front of you to get it better, because that's going to impact your selection of therapy. So quadrant 1's when you have limited psoriasis, limited arthritis, probably something that's not progressive in arthritis. Can you use NSAIDs? Can you use topicals? Can you use methotrexate? Methotrexate's a pretty weak drug in psoriasis and is modestly effective in psoriatic arthritis. But you can do things that you have time, you're not in a rush. Quadrant 2 is extensive psoriasis and mild arthritis. Those are the people who show up in the dermatology office primarily. And those are the folks who you have to think, what's going to get their skin better? Because while we want to treat their joints as well, that's not the priority moving forward. Limited psoriasis and severe arthritis, the other way around. Maybe you want to use preferentially an anti-TNF, which isn't quite as good as some of the newer agents in treating psoriasis, but they're highly effective for psoriatic arthritis. And then finally, the extensive psoriasis and severe arthritis, you really need to hit on something that's going to hit both of them very hard. You have to think about what the patient in front of you, what their priority is, and what is the thing that needs to be treated most quickly. So we're going to go through a couple cases that I think will hopefully bring out some of the major issues that we see when we're treating patients with psoriasis. So this is a 28-year-old woman who walks into the office. I think that most people can make the diagnosis of psoriasis from across the room, and most people can make the diagnosis of psoriasis across the room. But she clearly has greater than 10% body surface area. I think that's pretty obvious from the picture. Now, she's a nurse. She immigrated from Romania about 3 years prior to my first seeing her. She has severe skin disease, no doubt, but she's had it since she's age 12, so she's had it for about 16 years already. She has joint swelling and pain and stiffness since age 18, so the psoriasis came beforehand. But it's really much localized joint pain, few fingers and toes. Sometimes she's swollen, sometimes she's not. We can't always tell if the swelling is related to the inflammation in her extremities from the psoriasis or actually within the joint space. And it's the stiffness lasts for an hour, hour and a half. It varies a little bit. She's a nurse, and she's significant difficulty finding work due to her cutaneous disease. Her fingers aren't impacting her ability to work, but her skin is preventing her from getting a job. And there's actually quite a bit of evidence that unemployment and underemployment is a significant, there's a significant impact of psoriasis, and particularly severe psoriasis, on employment status. So I would put her in quadrant 2, right? She has skin predominant disease, early joint disease, but that's not what's driving her. She needs to get better quickly. So a more significant issue related to quality of life, potential comorbid disease is due to her skin. And as I said, I consider employment issues comorbid disease as well. Topical therapy, as Dr. Strober just said, and phototherapy just ain't gonna work. You guys might have colleagues who are in dermatology who will say, oh, I always have to go through topicals first. If you have this much body surface area, it is completely absurd to try topicals before you try systemic therapy. And in fact, there is clearly a relationship with that 10% number, is that effectiveness of topical therapy goes way down at that 10% number. So this is a patient who needs internal medicine, has systemic therapy, but then how do you choose in that zoo of biologics and orals, what is the best treatment for her? She has some pretty good evidence for joint disease, so you don't want to ignore it. And so should we determine therapy based on what's best for her joints? She has a chronic disease, and so does speed matter in this? And I think that's an important question for everyone treating psoriasis. So there's a guy named Mark Lebel, who many of you know, who used to be the chair at Mount Sinai in New York, who would always tell about how speed is centrally important for all his patients, because he has politicians, he has actors, he has all these really important people who have to get better really quickly. So speed is something he really looks for a medication. Not a big issue for me in Milwaukee, right? And so you have to think about that patient in front of you and what's really driving them to get better. As Dr. Strober just said a few moments ago, some drugs are a little faster than others, but what we have today is so much faster than we had 10, 15 years ago. It's almost silly to even consider some of it sometimes, unless it's a really emergent thing. And the most, who knows what the most emergent issue for getting someone better as quickly as possible for psoriasis is? Anyone have a guess? Weddings, yes, absolutely. Thank you very much. I have treated more patients on cyclosporin without that much psoriasis for weddings for my entire career. And then your local dermatologist really only uses oral medication and apremilast, which is not an unusual situation, and does not prescribe biologics. Is that an okay place to start? And I think that's another question you have to ask for the patients. First of all, I just want to put out psoriasis methotrexate data, and I'm going a little off topic here, but I think a lot of rheumatologists don't know the methotrexate data for psoriasis, so I just wanted out there. This is the best trial of methotrexate called the METOP study. It was published a number of years ago as sub-Q methotrexate, actually aggressively dosed with 17.5 milligrams to start sub-Q. And if you look at it, the PASI 75 result comes out to be about 40 or 45%. If you think about that in the context of what we're talking about with the newer biologic agents, it's pretty poopy, okay? It's better than apremilast, it's better than acitretin, but it's not a particularly highly efficacious nor speedy treatment for psoriasis. So I'm going to put it out there. I'm not going to talk a lot about methotrexate, but I just want everyone to have some sense of where methotrexate fits in terms of the efficacy related to some of the agents we're going to talk about soon. So I like to think about things as classes. Instead of trying to think about each individual drug, I think in terms of big picture. And that's how I'm trying to decide what's best for the patient. So when we say, okay, you need systemic therapy, I say you have oral medicines, you have biologics, and let's think about the classes of medications. And do certain classes work better than others? And the answer is, yeah. But are the differences really all that significant? In some cases they are, but if you look at this is a network meta-analysis, and assuming all the difficulties in doing that kind of analysis, I just want to point out that you see to have a couple groups that seem to have different levels of efficacy, and they almost break out themselves. So you have the first 3 or 4, sort of risankizumab, brodalumab, guselkumab, and ixekizumab being significantly higher effectiveness. Then you sort of a middle range between secukinumab, ustekinumab, certolizumab, adalimumab, and then you get to things that are particularly less efficacious, including etanercept and methotrexate in there too, as well as apremilast, and placebo tends not to work very well. Thank you very much. And so what you see is you have classes and how these work. Now sometimes there's crossing, so ixekizumab being an anti-IL-17 and risankizumab being an anti-IL-23, both fit into that highly effective group. So you have certain groups that tend to be highly effective and then sort of modest effective. What does the PASI 75 or PASI 90 mean? It's a positive predictive value. what's the likelihood of that patient going to get better as the first shot agent, right? So think about ACR 20 or ACR 50. It's the same thing. It's what is the predictability of this medication going to be? And the patient I showed you just a second ago, that predictability is really important because she's really got a ton of disease and she can't get work. So you want something in that very high predictable group. This is looking at quality of life, which says basically the same thing. It's a number needed to treat analysis. But you see that in the top performing drugs, there's not all that much difference. So if you're just looking at predictability, you're not going to see a massive difference between, say, risankizumab, which a lot of people think is the highest efficacy drug, and ixekizumab and guselkumab. They're all in the same ballpark. And that comes out even clearer when you see head-to-head trials. Now, head-to-head trials are obviously designed by the people who are sponsoring the trial, right? So you're going to have things that are going to be very effective. So if you look first to the figure on the right, which is the Eclipse trial, which was guselkumab versus secukinumab, you see early on, there's really no difference between those two groups, and there's a non-inferiority analysis that's done where they're pretty similar. But you can see that the anti-IL-17 might work a little faster, but it's still pretty quick. Primary endpoint, that is down a year going down, it's probably guselkumab did win statistically, and that actually is a pretty significant difference. But it's not tremendous. There's no reason you couldn't start looking at secukinumab as a drug of choice. Ixora is ixekizumab, again, the speed favoring the anti-IL-17, but overall efficacy, and by week 24, this becomes pretty even. So what did we do thinking of all these factors? Psoriasis predominant over psoriatic arthritis, needs to get better quickly, and is someone who really needs therapy because of her overall health. So she's skin predominant, so we need to see something that has predictably high level of effectiveness. We go directly to the anti-IL-17s and anti-IL-23s. Speed is important. She needs to get better. She can't get work. Anti-IL-17 has a marginal benefit, though not overwhelming advantage. Likely some peripheral psoriatic arthritis. Anti-IL-17 is probably a bit better. I think we all have a sense of that, but IL-23 is possible. So it looks to me that there are enough things favoring going with an anti-IL-17 that that's where we went. And we went for ixekizumab for her. And she got better. She was down. I have this weird habit of forgetting to take pictures of people when they're doing well. I only take pictures when they're really bad. And so I don't have a follow-up picture, and I apologize for that. But in actuality, she did quite well. She actually became employed at the hospital I worked at, and was quite happy and has remained on ixekizumab now for a few years and has stayed stable. So again, the skin driving it, the joints being a lesser concern, speed being a lesser concern, but still important enough that that's where we choose to go to the drug that favors those two elements. Make sense to everyone? Let's go to the next case. This is a 23-year-old woman. This woman and I, 32-year-old woman, excuse me. This woman and I have had a long history of taking care of her. I'll tell you a really funny story. So my wife's a gastroenterologist. And when she became pregnant, she lived way out in the suburbs. She had a horrible pustular flare of her psoriasis, and she walked into my wife's office for hyperemesis, and she had a horrible pustular flare of her psoriasis as well. And my wife goes, "You really need to see a dermatologist." She goes, "Yeah, my dermatologist, I called him, I couldn't get in." She had no idea that my wife and I had the same last name, that we were related in any way. And so my wife calls up, "Can you take care of this woman who's trying to get through to an office that can't get into that horrible dermatologist?" So yeah, it's my patient here. Thank you very much. But she's a really nice woman and has a long history of work. So this is when we first started seeing her, when she was 23, and it essentially looked about the same as she did now. Essentially, she presented initially to rheumatology for multiple tender and swollen joints in her early 20s. She was in college, and she stopped out of college for about a year because she just had horrible joint disease, and she was having a hard time writing, things of that sort. And so with her being at a young age, and with her sense that she was sexually active, things of that sort, she wanted to get started on certolizumab. The decision was started on certolizumab every other week because of the concern of pregnancy in the future, and had a great response. Her joints did really well. But her skin pretty much looked like we showed those leg lesions right now, which was better than she was at baseline, but still quite a bit active, and for a young person, still very concerning. So what do you do in a patient where she has psoriatic arthritis? It's under control, but her skin then becomes the issue. So there's no question her joints were the predominant issue to begin with. But that's now changed because her joints have gotten under control. Because it's one of those times that the rheumatologist was smarter than the dermatologist, right? So what do? Do you add topicals or phototherapy? Do you change the dose of certolizumab? Do you add methotrexate? Or do you change the biologic completely? So let's go through our thinking about her. The first thing is, and I like to be a kind of a common sense kind of guy, of course you add a topical. Going to the dermatologist's office is similar to going to a bagel shop. You come out with a schmear, right? There's a well-known dermatologist named Jerry Bagel who once was in the back of the room when I made that joke and yelled, "That resembles me." But the fact is, it is the easiest thing to think about. Now topicals can be pretty complex because you all have said, okay, let me just try giving you the one topical I might remember, which is triamcinolone, because I can't keep all these things in my mind, or fluocinolone, or whichever one it is. And they'll say the pharmacist say it can only be used for 2 weeks. You can't be used on pretty much any part of the body because it's too strong. What do I do? Turns out topical therapies aren't so difficult. Topical steroids are highly effective. You have to be concerned about the face, the underarms, the groin area, and that's about it for thinking. And use is, most people don't use it enough because it's so hard to be adherent to the therapies to get actually any side effects of it. If someone has over 80% of the body surface area, you hope they're not using it all over their entire body as well. There are going to be, as Bruce pointed out, a couple new topicals over the next 6 months to a year. One's called Rofumilast and one's called Tapinarof, which actually might take the question of what parts of your body you can't use topical steroids on, might take that out of the question, which might be a huge boon for ability for anyone to prescribe topical therapies. But the point is, of course you use a topical therapy. And she has thick skin on her legs, so you can use anything that's pretty potent. So we gave her a topical corticosteroid, we gave her fluocinolone, which is pretty potent, and said go ahead and use it until you get better. It's really interesting how little information we have about adding topicals to biologics. There really has only been one good study, and that said that actually adding topicals to adalimumab made it worse. We sort of thrown that one out. We're not paying attention to it, but probably didn't add a whole heck of a lot. And you can use the mild potency or high potency. Something a little stronger is absolutely fine. But what about the dose of the certolizumab? And this is looking at Symposi 1, which was a trial of certolizumab, and it's pretty clear that 400 milligrams every other week chronically works better than 200 milligrams every other week for certolizumab. So the question is, in a young woman who is happy to be on certolizumab because of other issues and her joints are doing great, can you change the dose of the medication? And the answer is, yeah. And the other thing is, can you change? So we don't have certolizumab comparators, but we do have comparators with adalimumab, and you can actually change the from a high-functioning anti-TNF agent, not as good as some of the more modern agents, and go to anti-IL-23 like guselkumab and get a high level of efficacy. So actually that crossover patients do quite well. And that's been now demonstrated with a number of agents. So there's very good data with Bendikizumab when it becomes available, with crossover from adalimumab, ustekinumab, or even Secukinumab as well. And so the possibility of changing is also quite reasonable. So what did we do? Well, as I said, we started the fluocinolone cream. And you know what? As a young woman, the likelihood of a young woman using her creams as prescribed is just, and this is even worse for young men, by the way, having boys, men now her age as my children, yeah, they don't use it, okay? The chance is almost zero. She couldn't come in for phototherapy, and she lived in an apartment, so she couldn't have a home UVB unit. I actually, through COVID, have used a lot of home UVB, where you write a prescription and someone gets a unit at home, they don't have to come in, they feel very comfortable. And we've used it a ton. But the first question you have to ask before doing that is, does the patient live in a house, or does the patient live in an apartment? Because the unit's about that wide and a bit taller than me, and putting it in a house is fine. You put it in the basement, it's not an issue. Putting it in an apartment and then move around theoretically, as a lot of young people do, it don't work very well. So phototherapy was really not an option for her. But since her joints were doing so well, and there was a reason to start the certolizumab in the first place, we decided to increase the dose of the certolizumab to 400 milligrams every other week. And she improved by about 75%. Was she completely clear? The answer was no. But she felt good enough that that was okay. I didn't have to push the envelope any farther. And so the last few spots, we actually brought her in. We injected a little interlesional triamcinolone into the remaining spots. And it pretty much cleared it up, and she stayed clear. In other words, we were able to just use the existing things and a little adjuvant to make her better. So we didn't have to go and to make big changes in the class of medication. So what are my takeaways from this? The main challenge to rheumatologists are the scenarios where the skin is the predominant issue, in my mind, or when the skin is not completely clear when the joints are doing well. And I think that's a challenge that all of us have faced frequently within our practices. For initial therapy, choosing based on skin as well as joint response is critical for the patient. The most recent biologics, that is the anti-IL-17s and anti-IL-23s, have pretty large advantages over the older biologics and oral therapies. Systemic therapies, even within classes, can behave differently. So as Dr. Strober mentioned, risankizumab and tildrakizumab don't behave exactly the same way. Risankizumab may be much more highly effective. And they behave differentially in the skin, and dosing may be distinct between the treatment of skin and joint disease. And that's one of the questions and one of my takeaways that I say in my psoriasis, psoriatic arthritis clinic that I've been saying for a year.
All right, folks, thank you so much for the invitation. I mean, it's a little tough after those two talks. I mean, what's left to say? I'm partly thinking I just open it up for questions and we end now. But it's all been covered. So a couple of disclosures and then I'll go through this. So first of all, you know, I love podium talks. I'm not sure if any of you can see me over the podium. I'll wave every once in a while so you know I'm still here. So I'll try to cover things a little bit different. There's going to be some overlap. This is me. I am in Boston. I'm a dermatologist and a rheumatologist at the Brigham and Women's Hospital in Boston. I checked the weather. Normally there's a big disparity. Today it's about the same. It's like in the 50s and gray. So, you know, more or less the same. But normally it's delightful to escape to warmer weather. And these are my disclosures. So I'm going to talk a little bit about the co-management piece. And I want to start first with gaps, a little bit more sort of the rheumatology facing gaps. And I think you've heard this. Some of this will be reinforcing to what my colleagues have already said, but I want to take a bit of a rheumatology angle on this. And you know, unfortunately, across the breadth of psoriatic disease, if you like that term, you know, we're siloed in our care, right? We have Ken doing psoriasis care as a dermatologist, you know, from a skin perspective. We're obviously sitting in the rheumatology world, worried about joints and the domains of disease around psoriatic arthritis. We had that lecture from Philip yesterday about axial disease, thinking about all the different components there. There's heterogeneity, you know, even within these two distinct areas. And then we have cardiovascular comorbidities and, you know, the primary care and the cardiologist there. We have other conditions to consider and a breadth of comorbidities, and we'll talk about that as well. So there are many gaps, right? And there's gaps in awareness. There's educational gaps between us as specialists, and there's access issues that came up a moment ago. And of course, time and resources, right, really keep the gaps open here between these areas and ultimately harm the patient from getting complete disease control. And here we are building bridges, right? So RheumNow Live is filling some of the educational gap there. But I want to focus a little bit on interdisciplinary care models, on research and innovation in this area, and how we start to think about closing these gaps a little bit more. You may notice the first author on this article, as they say where I come from, Addy, is listed there. And this is an important one. I want to use this to frame some of our discussion because what this essentially shows is that in order to maximize quality of life for our patients with psoriatic disease, one has to, maybe not surprisingly, but I'll pick it apart a little bit, not only control their joint disease or maximize or optimize their joint disease, but also their skin. And, that's not just the really bad patients that we saw a moment ago in the photos. It's also patients with 3% body surface area and more. So it still does matter very much. And, I won't, Ken, in a moment, I will unfortunately show one of the treat to target slides, but I will give a caveat. I promise there's a caveat when I get to that. But do remember this, because it really does matter to patients, and most patients. Is it different for my 70-year-old male VA patient with 3% body surface area than it is my 17-year-old female patient in the office? Possibly. I don't want to draw or over extrapolate there, because obviously it's a shared decision making discussion. But the point is, the skin still matters. So what are some of the rheumatologist gaps? I think although there is the classic plaque psoriasis patient that we saw again in Ken's presentation, there is often a differential diagnosis. I'll show you a few where there can be some gaps around here, especially in non-plaque or non-obvious psoriasis. Comfort with topicals and combination therapies you've been hearing about all morning. We'll talk about that a little bit. Comparative effectiveness data. We got a beautiful talk from Bruce about that this morning, but really staying up to date with that so we understand what we might be choosing or what we might be discussing with our patient who still has a sufficient amount of skin disease. Drug-induced eruptions, I won't have a lot of time to talk about them. I'm happy to chat with folks offline about that, or come back next year and chat about this. It's its own topic, and it's really fascinating to think about anti-TNF-induced psoriasis and other eruptions we're now seeing with some of our agents, IL-17-induced or exacerbated atopic and eczematous dermatitis, and other things that are really interesting. Appreciation of burden of disease, again, that skin matters. And then thinking about examining our patients with these other at-risk skin phenotypes, namely inverse intertriginous disease, nail disease, and other things. I'll show you those in a moment. So this is just a representative sampling of one of the things that I see. Now, depending on whether I'm sitting in the dermatology office or in the rheumatology office, I get a little bit of a different flavor here of what's coming across. And I will often have colleagues say to me, boy, I have this patient with psoriatic arthritis. I've started them on an anti-TNF. I'm waiting for it to kick in. And boy, their psoriasis just isn't clearing. And, and unfortunately, these are examples of nummular dermatitis, of eczematous dermatitis, contact dermatitis. And this is where some of the educational gaps and the co-management collaboration come in, because it's not psoriasis, right? And sometimes it can be a little bit tricky. It's not always clear cut. And so I think, getting more comfortable with this ourselves in terms of, just education and awareness, and otherwise just having a partner in this is another point we'll talk about. And I really like this. We've done some work on this over the years, and we had a publication a couple of years ago that showed that inverse psoriasis was common, in fact, and upwards of 25% of patients had some element of inverse or intertriginous psoriasis and body folds. What's interesting about this is what I found is we have a good number of patients who present with sort of a seronegative inflammatory arthritis, and they don't get a specific label. And in fact, if you get them undressed, if you look at some of these areas, I think it really helps us get to a diagnosis of psoriatic arthritis, looking in the gluteal cleft, looking in body folds, axilla, and other areas. And so something to think about. And in fact, this phenotype is associated with increased risk of psoriatic arthritis. Treat to target, can cover your ears. I just point this out for the rheumatologist for awareness. I think he and I are more aligned than not, that not everyone needs to be below 1% body surface area. I think it's a shared decision-making point. However, if you're seeing a patient where you are giving yourself a high five in the office because you have fixed their joints, but they still have substantial skin disease, I think it is our job to offer them either ourselves a therapeutic intervention for that, or to talk about referring appropriately, and we'll talk a little bit about those overlap care models in a moment. So this is a scenario that's come up a few times. So the patient with well-controlled PsA, say on the TNF, but they have active areas of skin disease. To me, this is not a minor piece of the rheumatology practice around psoriatic arthritis. So let's unpack a few of those gaps again. So okay, patient's not clear. Treat to target would suggest they should be less than 1% body surface area. At least we're going to have a discussion to say, well, how clear do you want to be? Perhaps that means some topicals. And for some of my colleagues, I repeatedly get, and from the same people, the same question, well, which topicals should I use, right? We'll talk about that a little bit. And you heard about those limitations today. And one of the big limitations is area, right? Is it genital, inverse face, scalp, et cetera, based on vehicle, based on potency, and that may become easier in a moment. Ken alluded to this a little while ago. Familiarity with relative efficacy data, you're all experts now after this morning's talk, so that's no longer an issue. Consider other combination therapy approaches, and then thinking about co-management. But often I hear, but there's a long wait time for the dermatologist, or it's challenging to connect with them. So we'll talk about that as well, where we can bridge some of those gaps. So what are the solutions for the rheumatologist? Pick a couple of topical steroids you feel comfortable with, and just keep using those, right? And understand that they're what the couple of differences are. You could probably get away with 2 or 3 and do a whole lot of good with that. However, there are new non-steroid topicals coming. Ken alluded to this, tapinarof or Flumilast, some topical JAKs and other things, that may be one size fits all. Of course, it's going to be price and access like everything else, but wouldn't that be nice if you could just say, well, you have a few stubborn spots, your joints are doing well, here's a prescription for X, and try that while they're either waiting to get into the dermatologist or maybe they don't even need the dermatologist at that point. That's fine. Combination therapy was already covered, and we'll talk about the co-management piece. I'm not going to cover derm gaps. I'll come back to this, but just to say each specialist in this, arena has their own gaps. For dermatologists, it's mostly around familiarity and comfort with the musculoskeletal history exam, screening around PsA and other things. I'll spare you all here. It is highlighted, though, by, and as a segue to our discussion about care models, the GRAPPA group, of which I am a huge fan and long-term member. I think, Philip, now 12 years or something like that, believe it or not. It feels like a family to me at this point. Did this work a few years back, and they actually had a group from KPMG, the auditing group and consultant group, who came in and took a look at where are the gaps in patient care around this. I'm going to highlight a few as it's relevant to this discussion about care models. But they said that we needed to develop referral pathways and or informal networks in order to really optimize care. And we needed to promote collaborative care between specialties, to establish multidisciplinary teams wherever possible. And when you pay that much to a consulting group, you have to listen to them, right? So I still don't know what consulting is, but anyway, that's fine. Let's just keep going. So combined clinics and facilitated collaborative care. So, look, here's a list of all the sort of comorbidities and the things that we're supposed to be doing to get our psoriatic patients sort of buffed and optimized, right? We should be measuring their BMI, talking about managing their modifiable risk factors, talking about alcohol and sleep, treatment satisfaction, PsA and skin, treat to target, lipids. Now, so here's the deal. We do have to do all of these things for the patient. Now, when you say this to a rheumatologist, I think they get it. And they also would say, it's a little bit like asking my kids to clean up their room, put stuff in the hamper, right? They can do it. It's gonna, right, all right, fine. You ask a dermatologist to do this, it's a little bit like asking a dog to write a haiku, right? It's not necessarily going to happen. So there are ways around this, right? And so I think at the bare minimum, it takes a team, right? And so I think it's very fair to say to the dermatologist, you own the psoriasis treatment, you have to screen for comorbidities, namely PsA, and then just help the patient build their team, right? We're going to talk about that a little bit more. Make sure they're plugged in with their PCP. Where we are, we have these preventative cardiology clinics now for rheumatology diseases. It's wonderful. I have a colleague who really wants these patients and is going to talk about modifiable risk factors, et cetera, right? So just getting them plugged in and making sure they're plugged in with the folks that are going to get all these things done, if not owning pieces of it ourselves, and we'll talk about that. True combined clinic. So this is great, right? And it's a little bit... it's a bit of an ivy tower construct in some respects. Where it can happen, I think it's wonderful, but there are other models as well. There is data that these truly combined clinics, where you have a derm and a rheum together in the same place at the same time, do improve outcomes. This is one publication that showed that combined clinic care in those combined settings that 46% of cases had a revised diagnosis, and they were much more likely to be treated appropriately with systemic or biologic therapy than before. Maybe not surprisingly, but I think that that's interesting. This is a little snapshot of our own combined clinic at the Brigham, where we have a dermatologist, a rheumatologist, a derm room person, myself, room fellows, derm residents. We have a derm room fellowship for 1 year, where either a dermatologist or rheumatologist comes through and cross-trains for the year. So it's great. It's a great education model. The patients love it. One-stop shopping. They only pay for parking once, right? They're thrilled. If we run late, they get we validate their parking. They're even happier. So anyway, and then of course it's a very rich environment for research as well, which I'll cover in a moment, and I hope helps to move the field forward to some degree. So this is great and it's wonderful. It's not practical everywhere. I'm well aware of that. Okay, and so what do the different collaborative care models look like? So there's these formal combined ones, and throughout different places in the country, we are aware of multiple different models. If you have one, we'd love to hear about it. Some that are in person every week, like ours, some that are monthly, et cetera, et cetera. Some are in tandem, but they're not on the same day. Some now are actually virtual. They have sort of virtual grand rounds. A couple groups get together, they share their complicated cases, they talk about it. Great. But some of the more practical ones are just connecting with someone in your community who is let's say on the derm side, who is not a cosmetic dermatologist. We're not recording this, right? That's a joke, yeah. Not a cosmetic dermatologist, someone who writes systemic agents for patients who need them, et cetera, and just finding that person and linking with them, right? Whether it's texting, phone a buddy. I will say if there's anything good that came out of COVID, facilitating these, discussions where HIPAA went out the window and we were texting each other for a little bit about patients and such. That was helpful. Communicate via electronic medical record. I'll come back to that. Sharing note templates is something, and I'll share it with you, a website where you can get some of those note templates with what the other party wants collected to understand why you're making the decisions that you're deciding on. And then really the key is just facilitated communication. And we have a few groups who have actually even agreed to hold a few templated slots for referrals that revert maybe a week or two before. They have one slot in their week for psoriatic arthritis referral or psoriasis referral, and they just keep it open so that you can get people in a relatively quick time frame. And all of these things can be helpful. And I'll share with you some resources to look at this. So.
Okay, thanks, Joe Merola. That was really great. Really three very interesting speakers. If you like those talks, you might want to go back and view them in their entirety. I enjoyed this session. This session had a ton of questions from the audience, and we actually went over on time because of the so many questions that we had. If you have any questions that you'd like to discuss here, the best place to do that is to use the Q&A box, if you will, and we can address those here. Right now, I have some questions from the meeting that were asked. A few people asked, how do I build my own referral network or my own dermatology consultancy, if you will? And that was generally an issue for those of you who practice in more rural environments where there isn't a dermatologist in your town, and patients are going to have to follow, or if they're to see a dermatologist, they're going to have to travel to do so. So what was a recommendation on how to best manage this? And there are several. One is, as Joe Merola spoke in that second to last slide, that you adopt one of those models, and that can be Zoom meetings with your derm colleague. You need to find a derm colleague that you can have a relationship. In Dallas, I've got a relationship with 2 or 3 medical dermatologists who are really interested in psoriasis management, for instance, lupus management. And we begin most of our, I need an opinion, I need a consultation with the cell phone. We're texting each other. We're saying, I got a patient here. Can you see them in the next hour? They live out of town. Or I take a picture. What do you think of this? And once you develop that relationship, that's the beginning of collaborative care. Obviously, you're going to hand that patient off, but the cell phone I find to be a tremendous tool in facilitating cooperative care. The second thing you can do is I think in this era of telemedicine and people getting familiar with Zoom, we're going to get into more peer-to-peer consultation and using telemedicine for that. I don't know if you've ever referred a patient to the Mayo Clinic or to the Cleveland Clinic, but you can get a peer-to-peer consult on a tough case, and the patient won't have to go to Cleveland or to Rochester, Minnesota. And sometimes it can just be you and the expert, like Carol Langford or Lenny Calabrese or whatever. I think that's going to be better managed in the future, meaning that there'll be a way of getting that reimbursed and charged to the patient's insurance, because it's going to benefit the patient. But these are a few things that can be worked out, especially if you're very remote. I want to underscore something that Merola said that I thought was really important. I missed the first time around, but I just heard now, and that was the patient needs a team. With psoriatic disease, the patient needs a team. And, you are one member of the team, and the question did come up several times, can the dermatologist manage everything? Can the rheumatologist manage everything? And the answer is yes. But would you do that with primary care issues and comorbidity issues? The answer is generally no. I want my patient to see the generalist, the family doctor, so that they'll do the, not just the COVID stuff, but the coronary stuff and the diabetes stuff and the vaccinations that need to be done, et cetera. And you don't have to do it, right? So the same can be said about psoriasis care, that I think a team approach might be the smart way to go. A question was asked about the deucravacitinib, the TYK2 inhibitor. There was a lot at EULAR about deucravacitinib, including a positive trial in lupus, some positive trials in psoriatic disease as well. Will it be considered and have as a JAK inhibitor? Will have the same warnings. We don't have an approval on deucravacitinib right now, and we're waiting on that. But if you look at the clinical trial results, whether they're done in dermatology, like that POET study, deucravacitinib head-to-head against apremilast, or in PsA, all the safety signals are reading out just as they would if this was a JAK inhibitor. And it is a member of the JAK family with some differences, as pointed out by Dr. Strober. So I fully expect that the boxed warnings that currently exist for baricitinib, upadacitinib, and tofacitinib are going to be carried over to other JAK and TYK inhibitors as they enter the marketplace, maybe not even in rheumatology, maybe just in, for instance, atopic dermatitis or alopecia areata. And again, the same thing here with deucravacitinib. What do you do? What's the story with JAK inhibitors in psoriasis? And the JAK inhibitors are going to be approved in psoriasis and also approved in psoriatic arthritis. But make no mistake, the JAK inhibitors are better at arthritis than they are at skin disease. And that's the equation: dominant arthritis or dominant skin disease. Dominant skin disease, you're looking at an IL-17, the dual IL-17, the IL-23, the 12-23s. That's dominant skin responses with that. But if it's dominant arthritis, you're looking at a TNF inhibitor and a JAK inhibitor, and getting good responses with using a 17 or a 23. But I think that it's an important decision. Is it more skin or more joint? Is it going to be the dermatologist, the rheumatologist, and which drugs you're going to use? I don't think it's that hard in the end. One question that was asked, and I don't have a great answer for it, except I'll quote one of the speakers. And the question was, for all the different types of psoriasis, is there one drug that responds the best to any one type of psoriasis? And that includes not only psoriasis, but psoriatic arthritis and dactylitis, enthesitis. I think that they're all kind of the same. We talked about the 17-23s versus JAK and TNF, but what I heard from Ken Gordon and also from Strober was that in clinical trials right now, it looks like the JAK inhibitors may have an advantage in the very difficult to treat palmopustular variants of psoriasis. And that's sort of unique, right? We said that JAK inhibitors generally don't work as well in the skin disease, not compared to the IL-17 and 23s, but maybe in palmopustular disease. So that's something to look forward to in the future. The question was, I got a patient on Humira for psoriasis and psoriatic arthritis. He's doing great for over 10 years. Should I switch? And my answer is no. If someone's doing great, you don't mess with it. There is no real long-term toxicity issue with the TNF inhibitors. Again, with most of the TNF inhibitors toxicities, whether it's a malignancy event, a TB event, infectious event, most of that's front-loaded, right? First six months, maybe 12 months. Someone's on it 10 years, you're not going to get anything new, and if you do, it's not going to be related to the drug. So my answer is no. You don't ever stop a drug that's working really well. And this question was about, should I switch to maybe a safer drug like the IL-17 inhibitors? And the facts are that the IL-17 and IL-23 inhibitors are safer because they've been largely approved and tested in psoriasis, where the signals for all the bad stuff, cancer, infection, and stuff, is less than you see in RA and Crohn's disease. That's why it looks safer. It's not really that it's safer, it's just that the patients it's tested in don't have as much in the way of those serious toxicities. Anyway, that's it. Let me see if there's any more questions here in the question board. I don't see any. I want to remind all of you that we are not going to do Tuesday Night Rheumatology next week. We're going to take a break for the summer. We'll start up Tuesday Night Rheumatology in September. I want to make a correction. This particular session and pod was sponsored by Novartis and not by Janssen. Thanks to Janssen. They did sponsor two other things during RheumNow Live, as did Novartis. And again, we're very thankful for Novartis' support of RheumNow Live. And lastly, I want to point out to you that we've got a lot of content this last week from EULAR. I mean, just a tremendous amount. I think we recorded over 75 videos. I think we had 1,000 tweets. I mean, just really incredible. Watch the videos. I think in the next few days, you're going to see a panel discussion on lupus highlights from EULAR 2022, and then early next week, an RA panel discussion. You might want to look at those. I thought those were really well done, and I got to sit in on them and moderate them. That's why I'm recommending those to you. So, and then lastly, this week on our weekly podcast, we'll be doing a roundup of what I think were the top presentations and takeaways from EULAR 22. Folks, thanks very much for tuning in, and follow us on RheumNow.